41 years male presented with chief complaints of neck pain radiating to left shoulder since 3 months, with weakness in left upper limb since 3 months. On examination, his blood pressure was 160 by 110 mmHg. Power in abduction and abduction of left upper limb was 1 by 5, with flexion and extension being 2 by 5. At elbow, power was 3 by 5 on flexion and extension. At wrist, power was 3 by 5. On MRI, cord edema with flow voids was seen from C3 to C6 level in left paracentral region, arising from left vertebral artery, leading to dilated epidural and paravertebral vascular channels, and causing compression of cervical cord. DSA was done, which shows high flow vertebral AV fistula at C3 to C6 level with direct shunting from left vertebral artery to epidural and paravertebral venous plexus. There was no filling from any other vessels. The treatment strategies were surgical ligation, transarterial route using balloon, liquid embolizing agent, coils, and stent grafts, transvenous grafts, and combined. We chose balloon assisted transarterial coil embolization of fistula with trapping of left vertebral artery as fistula was high flow and site of fistula was less evident. Balloon prevents any distal migration of coils and tight packing of fistula. Occlusion test was done prior to the procedure and was well tolerated by the patient. Liquid embolizing agent should not be used in cases of high flow AV fistula as there are high chances of distal migration of the embolizing agents into the arteries and into the venous plexus. The transvenous routes are reserved for complex multiple feeders and large stent grafts are required for the same. Surgical treatment is often difficult and leads to suboptimal ligation and increased chances of injury to the surrounding tissues. The hardwares required were femoral sheath 8 French, envoy guiding catheter 6 French, distal access intermediate catheter, echelon microcatheter, which is DMSO compatible, and if there's requirement of glue embolization, it can also be done through the same. Transform occlusion balloon catheter, target 360-degree coils. After taking consent, patient was laid supine in DSA lab. General anesthesia was given. Bilateral femoral artery puncture was done with 8 French femoral sheaths. An envoy guiding catheter of 6 French was taken up through the left femoral artery and placed into right vertebral artery. This was done so as to get cross flow and make road maps for the procedure. Similarly, through right femoral artery, a distal access intermediate catheter is placed into the left vertebral artery just before the fistula site. A transform balloon and echelon microcatheter with microguide wire is inserted through the distal access catheter. Fluoroscopy taken and road map is given. Transform balloon is placed beyond the fistula site and inflated, while the echelon microcatheter is placed at the fistula site, which is used to put coils into the fistula. The coils are put through the echelon microcatheter while the balloon is kept inflated. After putting in coils, we take fluoroscopy from the opposite side. We can see that the dye is still passing into the fistula. Therefore, more coils are put into the artery. The coils are put in with balloon kept inflated. Once sufficient amount of coils are put in to block the artery, the balloon is deflated and gradually withdrawn below the fistula. After putting in more coils, fluoroscopy is again taken from the contralateral side to look for filling of the fistula. This time we can see that no dye is going into the fistula. Finally, fluoroscopy is done from the left vertebral artery. AP and lateral view can be seen, which shows that no dye is going into the fistula, thus completing our procedure. Follow-up video at 1 month shows marked improvement in the symptoms of the patient, with improvement in the blood pressure of the patient on postoperative period day 1. The immediate correction of blood pressure was attributed to decrease in venous return once high flow fistula was blocked during the procedure.